So we start with patient selection. Most of us have found ourselves sitting in this very room, listening to an M&M presentation thinking, this patient sounds really sick. I wonder what would have happened if we just hadn't operated on her. For some of our specialties, these bad outcomes are inevitable. The patient protoplasm is stacked against us from the start, and especially with the complexity we see at Stanford. And when we say no, it can feel like we're damning the patient. Even still, I would say we strongly consider medical comorbidity, but all too rarely do we hold psychiatric comorbidity with any esteem. I believe this is a missed opportunity. The genesis for this talk actually comes from this paper. I was an eager third-year medical student at the University of Colorado, and Dr. Mann, a general otolaryngologist at Denver Health, agreed to meet with me to chat about research. We came away with this idea to investigate medically unexplained symptoms, or symptoms for which there's no physical evidence to explain. In Dr. Mann's county clinic, each patient writes down their chief complaint and fills out a 70-item review of systems questionnaire. For this study, we looked at 600 patients and found that the more times a patient endorsed a symptom on that intake form, the less likely we were to find the cause. In other words, a patient who presented with a pan-positive review of systems form was likely to remain a medical mystery. Meanwhile, those patients who came in with a chief complaint of nasal obstruction and simply checked nasal obstruction were likely to have a cause, a deviated septum and big turbinates. You'd think patients with dozens of symptoms would have evidence of pathology on exam, imaging, fiber optic scope, but in fact, the opposite was true. You can see that reflected in these charts here, and that higher review of system scores also correlated with advanced psychiatric comorbidity. And the signal we are capturing here is somatization, which is the physical manifestation of underlying psychiatric distress. And while these patients presented to see a surgeon, somatization is not treatable with surgery. So from this strange study, I internalized two important early learnings about patients. Number one, the psychology of illness, especially surgical illness, is complex. And number two, through forms or questionnaires, we might be able to screen for psychiatric origin of chief complaint. So a few years later, while trying to impress Dr. Most, these early learnings sparked a hypothesis. I theorized that we could use a pre-op patient-reported outcome measure to predict a patient's outcome in rhinoplasty. The idea being that for certain rhinoplasty patients, non-surgical factors seem to have this outsized effect. We chose to study patient psychology as one of these factors. It's worth noting that 1 in 10 facial plastics patients screen positive for body dysmorphia on the gold standard metric, whereas only 40% of those patients are clinically suspected by the physician. So not only is body dysmorphia common, we aren't good at identifying it. An important caveat, body dysmorphia and somatization are not exclusive to facial plastics or cosmetic surgery. We've all seen patients who are overfixated on perceived illnesses, defects, or ideas, and are consequently unhappy. But given the prevalence of body dysmorphia and facial plastics, this seemed like a reasonable place to start. So we interrogated the SCHNAZ, which is a 10-item disease-specific and validated questionnaire, to see if any of the items correlated with revision rates or rates of revision consultations. In particular, we zeroed in on item 5 in the questionnaire, which is decreased mood or self-esteem due to the nose. Decreased self-esteem implies body shame, and there's a clear distinction between body shame and body dissatisfaction. If we're body dissatisfied but have good self-worth, well-executed surgery should be effective. But if we have body shame leading to low self-worth, a scalpel is probably not the appropriate instrument. And so in our study, here's what we found. For this item, number 5, decreased mood and self-esteem due to my nose, those patients who endorsed the highest disease burden preoperatively for this item had an overall revision rate of 17% and requested a clinic visit to discuss revision 36% of the time. Just so everyone knows, 17% is 3 times the mean. Compare this against those patients who selected low disease burden for item number 5, who had an overall revision rate of 0%, and only 10% ever requested a visit to discuss revision. In light of these data, it's easy to see how even successful operations infrequently make patients happy. The indication was never surgical. Teasing this out is challenging, and figuring out what to do with the data even more so. As far as I know, other than refusing surgery or sending the patient back to their PCP, There's no formal mechanisms to guide patients who raise body dysmorphia flags towards appropriate resources. And again, this is not just for cosmetic patients. Somatization counts for 1 in 5 subspecialty consultations, and ear, nose, and throat complaints are the third most common. Think about your patients on whom you did what you felt like was a perfect surgery, and yet they kept coming back dissatisfied. They're difficult to say no to, and even trickier to identify. But if we don't try, we will continue to operate on a certain segment of patients for whom there is no surgical cure. So to recap, patient selection is one avenue to potentially improve patient outcomes. By being thoughtful about comorbidity, in particular psychiatric comorbidity, we might have a better chance at making patients happy. But now we can get into the meat of this talk. What about everyone else? Assuming our surgical execution is perfect and we pick patients we can actually cure with surgery, how do we maximize their chance of being happy? First off, I think a frame shift is required in how we think about patients. To get into the headspace for this talk, I had to stop thinking about patients as patients and start thinking about them as consumers. As surgeons, we are loath to consider patients consumers, as if it somehow cheapens our training in our professions. But at the end of the day, we are a service provider, an accommodating innkeeper, a trustworthy mechanic. Of course, we have certain standards of ethics and professionalism, but we are fundamentally a small business owner with a services offering. And our patients make consumer choices about their healthcare every day, which provider to go to, whether to take medications, whether to seek additional care to stop smoking. And only by making this frame shift in thinking can we really dig into the patient's consumer experience and everything wrong with it. Hidden away in the patient experience stack are numerous complex, friction-filled steps that make the reception of care uncomfortable. That's the burden of being a patient. And because medicine is so complex and slow-moving, and because as providers we have prioritized exceptional medical care over the patient experience, little progress has been made in improving the consumer aspects of healthcare. But the seeds have been planted for innovation. Services like on-demand pharmacy delivery, telemedicine consults, at-home lab tests, and wearable technology have allowed for more touch points, more surface area between provider and patient. As we progress into an increasingly digital future, patients will expect more frictionless services. I can tell you I've met the teenagers of today, and they will not tolerate many of the current consumer healthcare experiences we have on tap. Better clinic experience, transparency with providers, on-demand offerings, these are all things we should be thinking about. So how do we not get left behind? Especially at a place like Stanford, where so much infrastructure and inertia is already built in, how can we differentiate our services to create a great patient experience? I think it's not unreasonable to start by looking to technology. One of the biggest grievances patients have with the healthcare system is a lack of transparency. We can see our lab results, but what does a white blood cell count of 13 mean? We read the CT report, but wonder the significance of a long styloid process. A little over a year ago, I began working on a computer vision study with Dr. Pepper. For this project, with funding from Stanford Center for Artificial Intelligence in Medicine and Imaging, as well as some software engineers, we built machine learning software that can analyze facial symmetry and videos of facial paralysis patients. Automation in facial paralysis is important because current methods are time-intensive and cumbersome. But as an interesting side project, I began conceptualizing the utility of this algorithm for a patient-facing application. Wouldn't it be great if a newly diagnosed Bell's palsy patient could open up an app, take a video of her face, make a few gestures, and receive an immediate report on her symmetry and overall movement? The patient could also view how those metrics compared against videos they took 1 week or 1 month prior, so she can see how movement responds to Botox treatment or cross-facial nerve graft surgery. The patient could actually understand the metrics their surgeon is measuring when they study their face. Think about how much more engaged such a patient might be in the coordination of their care and their provider's recommendations. Silicon Valley is our backyard, and we have access to some of the brightest consumer scientists in the world. These are resources that we should all be thinking about capturing for our own practices. Because so little has been done in the space, there's so much opportunity to create value for patients. Well, this project is in progress and we have to measure patient use and perception of the app. Projects like these seem to be a reasonable first step if we truly want to offer an exceptional patient experience. And this next story brings us nearly to the present. Just a few months ago, I saw a patient in clinic for a post-op check. Although we had never met, the patient was cold and standoffish. As I examined her and we spoke more, she revealed that the 24 hours after surgery were incredibly challenging. She described a persistent nosebleed of unclear significance, confusion regarding which pain medications to take, and conflicting postoperative instructions. She called the nursing hotline and was transferred around for hours before her questions were answered and her concerns were managed. One of my guiding practices with patients is to think of them as my own mom. When I imagined my mother explaining this experience to me, it made me feel sick. Properly motivated, I got to work on another project, partnering with an enterprising orthopedic surgery resident named Deepak Chona to build a perioperative application for patients. This is the architecture for an application used for patients to help guide them through the perioperative period. The demo is currently very orthopedic surgery flavored, but that's all customizable. So let's say you're a thyroid surgeon and your postoperative care is well regimented. Your wound care instructions, how to take thyroid medications, what to do if symptoms of hypocalcemia occur, can all be uploaded in the app. Short videos can even be included of the surgeon explaining certain aspects of the postoperative period, so the experience feels tailored to the patient. On the day of surgery, the patient gets a message from their app with detailed instructions on where to show up and what time. And after the surgery, the app checks in again, and the patient can ask basic questions from a menu of options. The app will ask patients about their experience throughout the first few days, such as, is eating and drinking going okay? And how would you rate your pain? If the pain score is high, the app will offer pain medication instructions and check in again to ensure the pain score is trending in the right direction. If not, the app might recommend the stronger medication or care team member to call. Meanwhile, there's a surgeon dashboard as well. From this dashboard, we, the attendings, fellows, or residents, can monitor the responses of our patients and receive notifications if a patient indicates instructions are confusing or reports consistently high pain scores. This creates an opportunity for intervention, turning a bad patient experience into a wonderful one. Imagine being that patient struggling with pain postoperatively, scared, wondering, is this right? And one of your physicians calls you to check in saying, hey, I noticed we aren't doing a great job controlling your pain. I'm really sorry about that. Tell me what's been going on. Such a moment is the consummate patient experience I think we should all strive for. Less friction for higher value touch points between patient and provider, so the provision of our care outside the operating room is a delight. The projects I outlined tonight are humble ones, basic first steps, but hopefully provide a scaffolding for all of us to think about how we can innovate the experiences of our own patient practices. I'm going to finish with this talk with a story that seems particularly pertinent to our discussion, one that's been motivation for me as a resident here for the past 5 years. When I was a fourth-year medical student at Colorado, I remember the exact moment I received my offer to interview at Stanford. I remember flying to California and nervously joining the other applicants in this room to listen to Dr. Jackler welcome us to interview day. During that speech, Dr. Jackler highlighted the importance of exceptional surgical care, that we would be trained to deliver that here. But he followed up by explaining that what Stanford OH&S was truly looking for was innovators, individuals whose endeavors can make an impact on the experience of thousands, if not millions of patients. He called this the brass ring for a physician. I remember looking the term up, discovering it's that very small, elusive ring that many of us perhaps reached for on the carousel when we were young. It's a powerful expression. For the residents and attendings listening, if I can echo that sentiment, don't stop at just being a great physician and surgeon. Find ways to become an expert at delivering an exceptional patient experience, because there's a lot left to do. And only by optimizing the patient experience do we have the best chance at making our patients happy. Shouldn't that be the goal? Thank you for your time and attention, for your mentorship and your friendship. Most of all, thanks for giving a raw state school grad with a chip on his shoulder the opportunity to become a Stanford-trained surgeon.
Well done, Tyler. Good talk.
Thank you. right. If anyone has any questions, I'm happy to answer.
Great job, Tyler. This is Sam. Thank you so much. I know this has been a passion of yours since you were a med student. Can you guys hear me?
Yes.
I'm wondering, with the app, it's very fascinating. The last one you were talking about, I'm wondering what you think about physician fatigue and over accessibility, because I know that personally, like all the messages I get now on Epic all the time from patients with all these questions, it's fine if you have 3 or 4, 20 or 50 patients in your practice. If you've got a few hundred, it gets to be very burdensome. So what do you think about that in the patient experience? Do we have to limit the number of patients we have? Do we need to have APPs handling these apps if they're answering questions, or what suggestion do you have in that regard?
Thanks, Dr. Most. I think there's really two fundamental uses of technology. One is to automate what humans shouldn't be doing, and two is to identify what humans should be doing. And so in regards to this app, in your comment, which I agree, I am not interested in having a piece of technology, that forces me to interact, call every patient every day to say, hey, is your pain well controlled? Okay, no, okay. And then, that's something that should be automated. The whole premise of this is to reduce all of that and just give notifications for the patients that are really struggling, so that your time can all be important time that creates an impact for the patient. And I mean, even you, who is very, very busy in your practice, at any given time, you probably have 5 to 10 post-operative patients in the 1 to 2 week period. And, maybe 1 to 2 of those at most might be struggling with pain control or instructions or something like that. In that light, I think that there's a lot of utility to have a piece of technology like this.
Yeah, thanks.
I have another question. I don't know if Zoom folks can hear me, but one of the things that I think is fascinating, you showed one of the projects that you and I worked on together, is if you have a good idea, you have a gap, right? You have a gap that you're going to address with something innovative. So you create this thing that performs a task. Then you have to interdigitate it and smash it in together with the rest of the healthcare system. That's sometimes it seems like maybe the hardest part, right? Because your surgeon coach thing is clearly going to at least collect some useful data and be able to indicate somebody who needs some help. But I think one of the things that I struggle with is when you have a good idea, is that how do you envision it getting home, And so just in general, when you were thinking about these things, not maybe just for surgeon coach, but how do people, what are successful stories of people how they kind of got something into the Byzantine epic dominated, infrastructure in which we live, but move the ball forward? Did you have examples that you looked to that were reassuring, in that light?
Yeah, I think to your point, Epic is really like a fortress, like a walled fortress that is really hard to get into. Chatbots exist the world over for surgeons to have perioperative instructions and things like that for patients. The dashboard is actually a little bit more of a nuanced component. So as opposed to it just being a replacement for like a handout sheet for postoperative instructions, it's something that the surgeon can intervene on. But to your point, there's companies like StreamMD, which is also a sort of a similar product without the dashboard. And if you have an app on your phone, it doesn't necessarily need to integrate into Epic.
Right. Right.
And similarly, those can all integrate into things like RedCap. And so, from a data collection perspective, as long as it's HIPAA compliance in the app, which can be done.
Yeah.
I think that there's still an opportunity.
Yeah. Sometimes I think healthcare is a little held back because it's not federated. Do you know what I mean? You cannot create something independent that can work well with, right? It's just that you've got these dominant, kind of platforms that they sort of become there's a lot of analogies for it, but it can push back on innovative impulses